So as most of you would know, India has a huge burden of infectious diseases, and we have had this burden for a very long time. There are diseases like malaria, TB, HIV/AIDS, vector-borne diseases, and then there are outbreaks which keep happening from time to time. Besides this, there is a huge burden of diseases like diarrhea and pneumonia, and now we are recently noticing a huge burden of hospital-acquired infections in our ICUs and hospitals. Now, what drives this huge burden? The sanitation conditions, as you all know, are compromised. There are poor infection control practices, both in hospitals and the community, and the malnutrition further adds to this burden. Also, there is a very close human-animal interface, which leads to a lot of zoonotic outbreaks, as we are seeing these days. One of the influenza outbreaks was a zoonotic disease, and also the scrub typhus and diseases like JE are now being increasingly seen. Although India has a very high burden of infectious diseases, but if you have to look at the number of ID physicians that a country has, the number of ID physicians are very few, as the curriculum for ID in a formatted structure is available in very few institutions. Also, the number of doctors per patient, the doctor-patient ratio as prescribed by WHO, we do not conform to those standards, and because of the low number of doctors to a fixed population of patients, the management of infectious diseases is mostly mishandled. Added to that is the problem of self-medication, non-adherence to medication, availability of drugs without prescription, the counterfeit or the spurious quality of drugs which are available, and irrational prescriptions. So all these factors, they add to the big burden of drug resistance as we see it in our country. Now, I would like you to focus on the last, this column on the right, where we see that same drugs are being used to, for example, is erythromycin, azithromycin, amoxicillin, ciprofloxacin, and ofloxacin. Now, these are the drugs which are being used to treat everything from fever to common cold to cough to sore throat to diarrhea. So this is something which needs special attention, and also we are the third largest producers of antibiotics in our country, but we unfortunately have a very weak regulations over the sale of antibiotics, as a result of which most of the antibiotics are available over the counter. Also, there is a large amount of antibiotic use in livestock, poultry, and agriculture. So, evolution of antibiotic resistance in our country is a direct consequence of selective pressure which the overuse of antibiotic is leading to. Now, why we are concerned about AMR now? Now, as I mentioned, we have had these HIV/AIDS, TB, and malaria control programs for a long time, but they have been mainly vertical programs. HIV program will look at only HIV. Malaria program will look at only at malaria. But even in those programs, we are seeing, because of the drug misuse, they are leading to compromising the gains that we made as a country towards control of these infectious diseases. This is not just for the developing countries. This trend is also being seen in the developed countries, where the increasing drug resistance to ceftriaxone, cefixime, and azithromycin are seen in developed countries for Neisseria gonorrhoeae. Then added to that is the limited diagnostic ability and availability of healthcare personnel, as I mentioned, and unregulated, inappropriate use of antibiotics. So all these factors are leading to claiming the lives of invisible victims, which are not being tracked by any system. And these drug-resistant pathogens, they continue to lurk in our hospitals, in our community, and in our ICUs as invisible threats. Now, to combat antimicrobial resistance, Government of India came up with the National Action Plan on Antimicrobial Resistance. It has 6 pillars: awareness and understanding, strengthening the knowledge and evidence, improving the infection prevention and control, optimizing the antimicrobial use, innovation in R&D and finance, and the leadership. So today we are, when we talk of antimicrobial stewardship, we are mainly focusing on the pillar number 2, which pillar number 4, which is optimizing the antimicrobial use. Now, the national response to antimicrobial resistance so far has been very, very far from satisfactory. One of the key reasons for this has been that we need surveillance data to decide what are the high prevalence areas for antimicrobial resistance and where we should be directing our intervention as well as resources. Unfortunately, the evidence which has been available so far is very weak. Most of the evidence would come from small network studies or from few labs which were driven by investigators. There was no common SOP. As a result, in spite of having large amount of data, we could not come to a nationally representative trend or a pattern because of methodological limitations of all these studies. Also, we as a country, we lack the comprehensive patient safety programs which are not there, and the One Health approach which is needed to have a full understanding of AMR as it exists in our environment, as in our animals or livestock, that is also missing in our country. ICMR initiated the Antimicrobial Resistance Surveillance Network in 2013, and now we have 20 hospitals across the in this network, and RIMS Imphal is one of the sites for this network. We are looking at 6 pathogens: Enterobacteriaceae, gram-negative non-fermenters, enteric fever organisms, diarrhegenic organisms, MRSA, Enterococcus, and fungal pathogens. Now, standardization, harmonization is one of the key for this network, and the first thing we created was the standard operating procedures which this entire network uses, which is based on the CLSI guidelines, and we also have initiated the external quality assurance program, and we have our own data management system to feed and analyze the data. Now, I would like to share some of the data highlights which we have had in past few years. Now, this is the data from Salmonella. As you can see, in 90s, we were seeing a lot of resistance to chloramphenicol, amoxicillin, and cotrimoxazole. As a result, we stopped using these drugs for treatment of typhoid. So, the susceptibility to these antibiotics, as you can see in the left graph, has gone up. It is almost 90%. So today, if you want to treat typhoid, it is better to treat the patient with a chloramphenicol, amoxicillin, or cotrimoxazole. Unfortunately, because of the overuse of fluoroquinolones, ciprofloxacin, ofloxacin, and levofloxacin, the susceptibility to these drugs is very, very low. Fortunately, we are maintaining good susceptibility to azithromycin till date. In the right, you can see there is increasing MIC to ceftriaxone, which is currently being used for treatment of typhoid in the country. The gram-negatives emerge as a very serious concern in our network, and most of the pathogens, they belong to Enterobacteriaceae, gram-negative non-fermenters, and some of them are staphylococcal. We also see a large number of fungal isolates. As you can see, there are almost 6% blood isolates which are fungi, and not many centers in our network were initially working on fungal infections, and over a period of time, with the support of Dr. Runalo Chakrabarti, who is the PI for the fungal infections, we have been able to build these capacities in our hospitals, and now we are getting the data on fungal infections also. So some of the key highlights in our network are that because of the overuse of carbapenems in ICUs and also the availability of oral formulation like ferropenem, the susceptibility to carbapenem is decreasing every year by 5 to 10%. So it is very important to use this particular drug with a lot of caution. Then we are also seeing increasing MIC to colistin. There is increasing MIC to tigecycline and linezolid, increasing azole resistance in the fungal pathogens, and the glycopeptide resistance has also increased in past few years. Now, something which is very scary is the colistin resistance rates in E. coli and Klebsiella pneumoniae. This is the data from 2017, and you can see that 37% of infections which are resistant to carbapenem are also resistant to colistin. So it is very, very important, and I urge all the physicians in this room to please consider it once when you prescribe carbapenem or colistin for a patient, that do you really need to prescribe that? And if you are sending out the cultures and getting back the culture report, please de-escalate. So this is something that we should be worried about, and we should be constant. ICMR network not just looks at the phenotypic resistance, we are also tracking the genotypic markers of resistance, and we look at all the genes which are responsible for the ESBLs and the penem resistance, and we see that these are the cocktail of genes which are important. All kinds of genes are present in these bugs. So if you look at these 4 bugs which are of prime importance to us, the E. coli, Klebsiella pneumoniae, Pseudomonas aeruginosa, and Acinetobacter baumannii, you have everything there. You have ESBLs, you have carbapenemases, you have colistin resistance there, and the Klebsiella pneumoniae has become hypervirulent. So it is very difficult to decide empirical therapy for these pathogens as to what you can use for the empirical therapy, because one drug may not be enough. Probably you need 5 or 6, but this is not a very good situation to be in. And we also know that the drugs which are in the pipeline, the combinations which are going to be made available in next few years, they are not going to be effective for the serine KPCs, the OXA48, and the MBL-NDM. That is why it is very, very important that we have the antimicrobial stewardship program in place. And that is the reason that today the RIMS is holding the AMSP workshop, so that we are able to sensitize each and every clinician on the importance of judicious use of antibiotics. As Dr. Pallav and few other speakers mentioned in the morning, the antibiotic pipeline is almost dry. We haven't had a new antibiotic, a new novel candidates after year 2000. And it is not even looking very promising. Although there are almost 20 candidates in the pipeline now, but it is going to take very long time for those drugs to become available for routine use. So antibiotic stewardship, using it rationally, is the only answer that we have right now if we want to save patients. Antibiotic stewardship is a coordinated set of interventions which are designed to improve and measure the appropriate use of antimicrobial agents by promoting the selection of optimal antimicrobial drug regimen, including the dosing, duration, and the route of administration. So what is the primary goal of this program? Primary goal is to optimize clinical outcomes while minimizing the unintended consequences of antimicrobial use, so as to reduce the toxicity, reduce the selection of pathogenic organisms, and reduce the emergence of drug-resistant pathogens. The secondary outcomes of this program is also that it helps us reduce the healthcare costs without adversely affecting the quality of care. So if we follow the local evidence and have our antibiotic policies which are based on the local evidence, it will ensure that patient receives optimal treatment, protect the effectiveness of broad-spectrum antibiotics, reduce inappropriate use of antibiotics for self-limiting infections like cough and cold, and ensure that healthcare professionals, patients, as well as the public, they understand the need to use antibiotics prudently. So here I would like to highlight, it is not just the health professionals that we need to focus on. We also need to educate the patients, and we also need to educate the public. And that's why a comprehensive approach on AMSP is required. Now these are the 2 pillars of antimicrobial stewardship program: the prospective audit with intervention and the feedback, and the formulary restriction. From the studies which have been done and the surveys that we carried out at ICMR, we know that most of the doctors like to do the prescription audit and the feedback, although it's a more resource-intensive intervention, but it provides an opportunity for education, and it doesn't limit the autonomy of the prescriber, whereas the formulary restriction sometimes is seen by prescribers as restricting their autonomy. Now, antimicrobial stewardship is not just responsibility of one doctor or one microbiologist. It requires a team in a hospital to practice antimicrobial stewardship. From my experience, I know that when we just started the Antimicrobial Stewardship Initiative, this was started under leadership of our former DG, Dr. Soumya Swaminathan, and she wanted to have a meeting with all the hospitals which are part of ICMR network, the management of those hospitals, so as to emphasize that they should allocate resources for AMSP. So whenever I would write letters to the directors of the hospitals or institutes to please send a AMSP team, most of the time the response is the microbiologist will attend. So it is not just a microbiologist who can help AMSP, it requires an administrator to provide logistic support, a doctor to prescribe antibiotics following the local antibiotic policy, which was released today for your hospital. A microbiologist to provide antibiograms so that the policy is based on the local evidence. A nurse's role in administering antibiotics safely and in a timely manner. Facilitating prompt review, therapeutic drug monitoring and adverse reaction monitoring, and the pharmacists to ensure that antibiotics are prescribed as per policy and provide prompt review. Now, the project that we are funding in across the ICMR network, we are funding 1-year AMSP program, and each project gets a pharmacist which is enrolled on the project, because we realized the administrative support can be created by talking to the administration. Doctors are already there, microbiologists are there, the nurses can also be trained. It is the pharmacist. None of the hospitals had the pharmacist, so that is why we have provided one pharmacist to each hospital. Now, these are the essential elements of AMSP besides a multidisciplinary team. You need a good microbiology lab. You need documentation in place which support AMSP practice, something like a treatment guideline, something like infection control processes, then education on AMSP practices, what we are doing today, a continuous process of education and creating awareness, an IT system for dissemination of the information and ready availability of the documents, and a system to monitor the process and the outcomes of the project. This survey we carried out in on AMSP practices as they were being practiced in hospitals in India. In this survey, we had 13 public sector hospitals and 7 private sector hospitals, and we found that none of the hospitals, except the private hospitals, none of the hospitals, especially the government, had any kind of AMSP document. Most of the hospitals had infection control document, but nothing for AMSP. Hospitals also did not have ID physicians. The AMR data analysis was being done by all the hospitals, but no hospital was looking at the antimicrobial usage data in the government sector. Only 5 were practicing. These were part of the private sector. Then the prescription audit and feedback was being practiced only by 2 hospitals. Most hospitals did not have any kind of a comprehensive treatment guideline, although a syndrome-specific guideline was available. And AMSP was not linked to IT system. So this survey actually highlighted a lot of gaps in our healthcare system, and this formed basis of the AMSP program that we then initiated from ICMR. So first thing that we did was that we organized trainings. These trainings were led by IT physicians, and we did 4 of these trainings across the country: Mumbai, Calcutta, Chennai, and Delhi. And we trained more than 150 staff, which included a 5-member team from each hospital, an administrator, a physician, a microbiologist, infection control nurse, and a pharmacist. So we invited a 5-member team from each hospital, and Imphal also sent a team. And we have by now we have trained more than 300 staff from almost 60 medical colleges on AMSP. And now we are also funding 1-year AMSP project in the ICMR network hospitals. So these hospitals have to create an antibiogram for their own hospital, create an antibiotic policy, and I can see the 2 of the things have already been achieved by your hospital. Carry out the point prevalence of cultures, carry out antimicrobial consumption assessment in the ICUs. So each hospital has been asked to pick few ICUs, and I think 2 or 3 ICUs are being picked in all the hospitals. This is the minimum number. Some hospitals are doing more also. And initiate audit for carbapenem and polymyxin prescriptions. Initiate the formulary restriction for polymyxins if possible, and carry out the workshops for education. And one of the event which is being organized today is part of this workshop, is part of this project. So antimicrobial stewardship is not easy to sell to administrators. Administrators see it as a resource-intensive and a finance-intensive exercise, because additional support in terms of human resources, in terms of the documents and the IT system needs to be provided. But literature shows that the countries or the hospitals which implement the evidence-based AMSP program, it is not, it just doesn't improve the patient safety profiles, but it also improves the community resistance profiles, and over the period of time you find that it is financially self-supporting. So there are different roles for different levels. The hospital leadership, it is very important for the leadership to create AMSP and infection control committees, then create the necessary documents, the HIC documents, the HIC guidelines, the outbreak investigation guidelines, the antimicrobial agents prescription guidelines, perform frequent audits, record healthcare associated infections, create systems to analyze AMR data, analyze antimicrobial usage data, and also implement the computer-assisted programs and the regular education programs. The clinicians and physicians in this room, I urge all of you to please follow the guidelines which is prepared by your hospital. Practice infection control as per the hospital policy, because your hospital is also part of a bigger program under the CDC, which looks at the infection prevention and control. Consult the pharmacists or the pharmacologists. Practice responsible prescription. Update yourself on new drugs and breakpoints, and also counsel the patients. Now, as I mentioned, there have been no new antibiotics. There were 42 antibiotics, which were only 15 antibiotics have been approved since 2000, and compared to 63 put to clinical use between 1980 and 2000. Out of these 40 new drugs, only 4 of them represent new classes of antibiotics which are targeting bacteria through novel mechanisms. Many new initiatives to encourage, not many new initiatives are there which encourage the discovery and the development of antibiotics, because the pharma industry, it doesn't make a lot of money on antibiotics, because once the antibiotic, pathogens become resistant to antibiotic, the companies stop making money on it. So private pharma has almost steered clear of it. That is why it is very important to have stewardship at all levels. At the regulatory level, the Government of India introduced the Schedule H1, which contains 46 fixed dose, 46 antibiotics, and there are 24 belonging to the third and the fourth generation cephalosporins and carbapenems, and 11 are anti-TB drugs. So, although the H1 has been the policy has been framed, but the implementation is not optimally happening on the ground, and it will take some time for this to roll out completely. Then, on the suggestion of ICMR, the drug regulator also banned 354 FDCs which also contain antimicrobials. Then there is a ban on colistin use as a growth promoter in livestock and poultry. Many of you may have seen this campaign which ICMR did in collaboration with Pfizer, and this campaign was to create awareness among the general public on the responsible use of antibiotics. Many of us have learned to value the resources like air, water, that they should be used with caution. But antibiotics is also a natural resource. We also have a limited supply of antibiotics, and that also should be used with caution. So for addressing AMR, just one thing is not enough. We need everything. We need evidence, we need infection control, we need rational antibiotic use. We also need new drugs and diagnostics. We need to understand transmission dynamics, and we need better regulations and awareness. Now, the 3 things which are most important for addressing antimicrobial resistance are to improve the diagnostic stewardship so that we are able to diagnose infections better, improve the infection prevention and control, and improve the antimicrobial stewardship. So today we are addressing the most important, which is the 3rd component, and this is just the beginning. We have only taken some baby steps in this direction. We still do not know what will be the best system or a best approach for introducing antimicrobial stewardship in our country, and we need continuous research in all aspects of AMSP to obtain the best program for our local needs. So for that, we need continued support from the hospital like yours, so that we are able to move forward in research on AMSP. Thank you.